Fezolinetant, Veozah, a new drug to treat hot flashes. Hi everyone, and welcome to the Pharmacy Tutor. Today I'll be spotlighting the use of Fezolinetant, a new drug treatment for hot flashes. This will be a concise review that will hopefully provide you with everything you'll need to know about the drug. Fezolinetant, trade name Veozah, is used to treat moderate to severe hot flashes due to menopause. It's an oral tablet. It's non-hormonal, so it's not a hormone. It's a neurokinin 3 or NK3 receptor antagonist. It owns a first-in-class unique treatment option, and it works by blocking the NK3 receptor, which plays a role in the brain's body temperature regulation. Let's talk about what happens during menopause. During menopause, a woman's body slowly produces less of the hormones estrogen and progesterone. A woman can experience a multitude of unwanted adverse symptoms due to these hormone levels going down. Symptoms include anxiety, hot flashes, irritability, headache, weight gain, fatigue, insomnia, and many others. The primary symptoms of menopause are genitourinary and vasomotor. Hot flashes are also termed VMS. The cardinal symptom of menopause is called VMS, vasomotor symptoms of menopause. It's characterized by hot flashes and/or night sweats. VMS is the most common symptom of menopause for which women seek treatment. Hot flashes or hot flushes is a sudden feeling of warmth in the body, usually most intense over the face, neck, and chest. It may be accompanied by sweating, reddening of the skin, chills, and rapid heartbeat that can last 2 to 4 minutes. Night sweats. Symptoms of night sweats are the same as hot flashes, but they occur at night. Night sweats may also cause rapid heartbeat and disrupt sleep. The triggering of hot flashes and night sweats are an attempt by the hypothalamus to cool down the body through heat dissipation. Vasodilation in the skin causes heat loss, which is experienced as hot flashes, sweating, and chills. Here are some interesting facts about hot flashes. About 60 to 80% of women experience VMS during or after menopause. 15% of women will suffer from severe hot flashes. Most women experience several episodes per day. The frequency of VMS varies from 1 per day to 1 per hour. Symptoms typically last 5 to 7 years, with a median duration of 7.4 years, although some women continue to experience symptoms for longer than 10 or 15 years. VMS affects a higher percentage of African American women and Hispanic women. VMS can disrupt a woman's daily activities and can substantially impact overall quality of life. Frequent 7 or more moderate to severe VMS episodes per day can interfere with sleep, concentration, mood, energy, and sexual activity. The intensity of VMS can be classified as follows. Mild intensity means a sensation of heat without sweating. Moderate intensity, a sensation of heat with sweating, but able to continue activity. And severe intensity, a sensation of heat with sweating, causing cessation of activity. Let's talk about hormonal treatment of VMS. For many women, menopausal symptoms are manageable. However, in a large group of women, this change in hormones can lead to symptoms that can negatively affect their sleep, mood, and quality of life. One of the most effective ways to treat these menopausal symptoms is to use hormone replacement therapy, or HRT. HRT boosts estrogen levels to relieve menopausal symptoms. There are 2 types of HRT. 1, estrogen therapy, and 2, estrogen progesterone progestin hormone therapy called EPT. Medication can be delivered in several ways, such as in pill form, as a topical patch, vaginal cream, or ring. However, This type of treatment carries risks. Patient taking HRT will have a higher risk of developing breast cancer, endometrial cancer, blood clots and stroke, and gallbladder problems. For women with moderate to severe VMS and no contraindications, HRT consisting of estrogen and a progestin or progesterone for women with an intact uterus, or estrogen alone for women who have undergone a hysterectomy, is recommended as first-line therapy. Although HRT is available, it may not be right for everyone since safety concerns will prevent some women from receiving this treatment. Contraindications to using HRT include the following health conditions: a history of breast cancer, venous thromboembolic event, VTE or stroke, coronary heart disease, blood clots, active liver disease, high risk of endometrial cancer, unexplained vaginal bleeding, or transient ischemic attack. Since HRT can potentially increase the risk of these adverse outcomes from occurring, these patients can try non-hormonal therapies over hormone therapies. Non-hormonal management of VMS can be considered when hormone therapy is not an option, either because of medical contraindications or a woman's personal choice. Surveys suggest that 50 to 80% of midlife women use non-hormonal therapies for menopausal symptoms. Because some women cannot or choose not to want to take HRT, non-hormonal therapies have been studied for the treatment of VMS. Women with mild VMS symptoms are encouraged to try behavioral approaches, such as lowering ambient temperature with cooling techniques, dressing in layers of clothing, sleeveless blouses, etc., or avoidance of physical and emotional triggers, such as spicy foods and stressful situations. Lifestyle changes can be considered, such as cognitive behavioral therapy, mind-body techniques, exercise and yoga, acupuncture, visiting a chiropractor, dietary modification, weight loss, and stress reduction and relaxation. What about prescription drug therapy for VMS? One drug that is used is paroxetine. Paroxetine, trade name Brisdal or Paxil, is an antidepressant medication. Currently, it's the only antidepressant that is FDA approved to treat hot flashes. It was approved in 2013. It is given as a low-dose form of paroxetine. Paroxetine is an SSRI, selective serotonin reuptake inhibitor. Paroxetine is not recommended for women with a history of breast cancer and taking tamoxifen, as it has been shown to interfere with tamoxifan's metabolism. Tamoxifen is a selective estrogen receptor modulator used to treat breast cancer. While paroxetine is the only antidepressant with an FDA-approved indication for VMS, other selective serotonin reuptake inhibitors, SSRIs, and selective norepinephrine reuptake inhibitors, SNRIs, have also been shown to be effective in treating VMS. There are 4 other drugs that are used for VMS, but they are all not FDA approved and are used off-label. The first 2 drugs are gabapentin and pregabalin. Gabapentin or Neurontin and pregabalin, Lyrica, are anti-seizure drugs. Gabapentin and pregabalin are often recommended for women with VMS who also have sleep disturbances, as they can aid sleep. The second drug is clonidine or Catapres. It's a drug used to treat high blood pressure, and it comes in pill or patch form. The third drug is oxybutynin or Ditropan. It's a pill or patch approved to treat urinary conditions and overactive bladder. Alternative over-the-counter remedies have also been used. Many supplements claim to help with VMS symptoms, but the evidence for the effectiveness and safety of these treatments is at best inconclusive. Among the remedies are soy foods and extracts, plant estrogen and isoflavone, S-equal derivatives of soy isoflavones, black cohosh, which is a phytoestrogen, dong quai, evening primrose oil, ginseng, red clover, vitamin E, and wild yam. So after that introduction, let's talk about our new drug, Fezolinetant, or Veozah. Fezolinetant, trade name Veozah, is a prescription medicine manufactured by Astellas Pharmaceuticals. Its initial U.S. approval came in May of 2023. Fezolinetant is a neurokinin 3 or NK3 receptor antagonist. Fezolinetant is not a hormone, and it comes as an oral tablet. Fezolinetant is a neurokinin 3 NK3 receptor antagonist indicated for the treatment of moderate to severe vasomotor symptoms, or VMS, due to menopause. Mechanism of action. Fezolinetant is a neurokinin 3 NK3 receptor antagonist. It blocks neurokinin B, NKB, binding on the NK3 receptor, which is located on the KNDY neuron in the brain. KNDY stands for kisspeptin neurokinin B dynorphin. What happens prior to menopause? Prior to menopause, there is a balance between estrogens and a brain chemical called neurokinin B, or NKB. This balance regulates the body's temperature control center, or thermoregulatory center, located in the brain's hypothalamus. Estrogen, in the diagram to the right in green, blocks the neurokinin 3 receptor on the KNDY neuron to inhibit VMS symptoms. On the other hand, neurokinin B, in orange, stimulates the neurokinin 3 receptor, signaling the induction of hot flashes. With the presence of estrogen and the balance with neurokinin B, this contributes to an equal body temperature regulation. However, during menopause, we see unopposed neurokinin B. As the body goes through menopause, circulating levels of estrogen fall, thus disrupting this balance. Neurokinin B signaling becomes unopposed. This imbalance disrupts the thermoregulatory center's ability to control the body's temperature, leading to hot flashes and night sweats, or VMS. You can see now in the diagram that levels of estrogen have fallen and neurokinin B has taken over unopposed. This triggers the VMS. What's the effect of using Fezolinetant? Fezolinetant blocks neurokinin B from attaching to the NK3 receptor, helping to restore the balance in the temperature control center. This results in a reduction in the number and intensity of hot flashes. So let's summarize Fezolinetant's mechanism of action. Fezolinetant is a neurokinin 3 NK3 receptor antagonist. It blocks neurokinin B binding on the NK3 receptor, which is located on the kisspeptin neurokinin B dynorphin neuron. By blocking this neuron, neuronal activity is modulated in the thermoregulatory center of the brain, the hypothalamus. The dose of Fezolinetant is 45 milligrams orally once daily, with or without food. It should be taken with liquids and swallowed whole. Do not cut, crush, or chew the tablets. It's available as 45 milligram tablets and should be stored at room temperature. If a dose of Fezolinetant is missed or not taken at the usual time, you should administer the missed dose as soon as possible, unless there is less than 12 hours before the next scheduled dose. Return to the regular schedule the following day. A major precaution with the use of Fezolinetant is the potential for liver injury. Elevations in serum transaminase concentrations greater than 3 times the upper limit of normal have occurred in patients taking Fezolinetant in clinical trials. Because of this, the following precautions must be taken. Before beginning treatment with Fezolinetant, perform baseline blood work to evaluate for hepatic function and injury, including ALT, AST, serum bilirubin total and direct. Do not start therapy if ALT or AST is equal to or exceeds 2 times the upper limit of normal, or if the total bilirubin is elevated. Also, while taking fezolinetant, perform follow-up blood work at 3 months, 6 months, and 9 months after initiation of therapy. Monitor for symptoms that suggest liver injury, such as nausea, vomiting, or yellowing of the skin or eyes. Should we adjust the dose of fezolinetant for renal or hepatic impairment? In renal impairment, fezolinetant is contraindicated in patients with severe renal impairment, an estimated glomerular filtration rate of 15 to 30 mL per minute, or end-stage renal disease. In hepatic impairment, increased exposure of fezolinetant occurred in patients with Child-Pugh class A or B hepatic impairment. Fezolinetant was not studied in patients with Child-Pugh class C hepatic impairment. Let's quickly go over the pharmacokinetics of fezolinetant. The mean time to reach Cmax is 1.5 hours in healthy women. The effective food, no clinically significant differences in fezolinetant pharmacokinetics were observed following administration with a high-calorie, high-fat meal containing approximately 1,000 calories. The mean volume distribution is 189 liters. The plasma protein binding is 51%. Metabolism. An important point to remember is that fezolinetant is primarily metabolized by the CYP1A2 enzyme, and to a lesser extent by CYP2C9 and CYP2C19. A major metabolite of fezolinetant was identified in plasma. The metabolite is approximately 20-fold less potent than the parent. The metabolite to parent ratio ranges from 0.7 to 1.8. The half-life of fezolinetant is 9.6 hours. Following oral administration of the drug, only small percentages of the dose was excreted unchanged in the urine and feces. Overall, 76.9% of the dose was excreted in the urine and 14.7% in the feces, mainly as metabolites. A main drug interaction occurs with the use of CYP1A2 inhibitors. Fezolinetant is contraindicated in individuals taking drugs that are CYP1A2 enzyme inhibitors. Fezolinetant is a metabolic substrate of the enzyme CYP1A2. You can see in the diagram that the drug is metabolized by the CYP1A2 enzyme to inactive metabolites. Concomitant use of fezolinetant with drugs that are weak, moderate, or strong CYP1A2 enzyme inhibitors increase the plasma Cmax and AUC of fezolinetant. You can see in the diagram that if a patient is taking a CYP1A2 inhibitor concomitantly, the CYP1A2 enzyme is then blocked, and so fezolinetant cannot be metabolized, and the drug levels will increase significantly. Here are some examples of CYP1A2 inhibitors. Strong inhibitors include fluvoxamine and ciprofloxacin, moderate inhibitors mexiletine, and weak inhibitors cimetidine, acyclovir, allopurinol, and xyluitan. All drugs are contraindicated with the use of fezolinetant. There are 3 main contraindications to using fezolinetant. 1. Severe renal impairment or end-stage renal disease with a GFR of less than or equal to 30 mL per minute. Cirrhosis and concomitant use with CYP1A2 inhibitors. As we stated earlier, fezolinetant has the potential to cause hepatic transaminase elevation. To what degree? Elevations in serum transaminase levels, ALT and AST, greater than 3 times the upper limit of normal occurred in 2.3% of fezolinetant patients compared to 0.9% placebo patients in 3 clinical trials. Women with ALT or AST elevations were generally asymptomatic. Transaminase levels returned to pretreatment levels without sequelae with dose continuation, and upon dose interruption or discontinuation. Special populations. Pregnancy. There are no data on fezolinetant use in pregnant women to evaluate for a drug-associated risk of major birth defects, miscarriage, or adverse maternal or fetal outcomes. For lactation, there are no data on the presence of fezolinetant in the human milk, the effects on the breastfed child, or the effects on milk production. It is not known if fezolinetant is present in human milk. Overdoses is treated with the institution of appropriate symptomatic care. And for carcinogenesis and mutagenesis, a 2-year female rat carcinogenicity study and a 26-week carcinogenicity study in mice, there was no evidence of drug-related carcinogenicity. The most common adverse reactions with fezolinetant were abdominal pain, diarrhea, insomnia, back pain, and hepatic transaminase elevation. You can see in the table that all side effects were less than 5% in the fezolinetant group and were close to placebo percentages. Clinical studies. The Bright Sky program. These were 3 phase 3 clinical trials. The trial was done at 97 facilities across the United States, Canada, and Europe. They investigated the efficacy and safety of fezolinetant for the treatment of moderate to severe VMS due to menopause. And the studies were sponsored by Astellas Pharmaceuticals. Trials 1 and 2 were called the Skylight trials. They were randomized, placebo-controlled, double-blind studies. They involved 1,022 women, 522 in Trial 1 and 500 in Trial 2. The women had a minimum average of 7 moderate to severe vasomotor symptoms per day. The co-primary efficacy endpoints were the mean change from baseline in frequency and severity of moderate to severe VMS at weeks 4 and 12. The initial study was for the first 12 weeks. After 12 weeks, women on placebo were then re-randomized to fezolinetant for a 40-week extension to evaluate safety for up to 52 weeks of total exposure. Data from the Skylight 4 safety study characterized the long-term safety profile of fezolinetant. Results. The mean age of the study participants was 54 years. It ranged from 40 to 65 years. 81% of the patients were Caucasian, 17% African American, 1% Asian, and 24% with a Hispanic or Latina ethnicity. 20% of the study population included women with prior hormone therapy use who underwent a washout period prior to the trial. Let's first review the results looking at the reduction in the frequency of VMS episodes. After 4 weeks in Trial 1, both fezolinetant and placebo groups had a baseline of 10 VMS episodes per day. Fezolinetant reduced the number of VMS episodes by about 50%, while placebo reduced them by about 33%, a statistically significant difference. Trial number 2 had patients with slightly more VMS episodes per day, but it saw about the same percent reductions as seen in trial number 1. It also demonstrated a statistically significant difference. Note that even administering placebo sugar pills resulted in some benefit. After 12 weeks, trial number 1 showed even further reductions in VMS episodes, about 60% for fezolinetant compared to about 40% in the placebo arm. Similar results in VMS frequency reduction were observed in trial 2 as in trial 1 after 12 weeks of therapy. At weeks 4 and 12, both trials showed a statistically significant greater than or equal to 2 hot flashes over 24 hours reduction from baseline in the frequency of moderate to severe VMS for fezolinetant compared to placebo. The adjacent figure illustrates the data from the results in a more graphical format. Women averaged about 10 to 12 episodes of hot flashes per day. At week 4, fezolinetant cut the number of hot flashes in half, by 5 to 6 per day, compared to 1/3 with placebo. At week 12, Fezolinetant cut the number of hot flashes down by 63%, by 6 to 7 episodes per day, compared to 42% with placebo. Now let's take a look at the results for the reduction in the severity of VMS episodes. After 4 weeks, in Trial 1, both Fezolinetant and placebo groups had a baseline severity score of 2.4, which equates to a moderate to severe level. Fezolinetant reduced the severity score by 0.5 compared to 0.3 for placebo, a statistically significant difference. Trial number 2 saw about the same reductions as in trial number 1, demonstrating a statistically significant difference. After 12 weeks, trial number 1 showed slightly smaller reductions in VMS severity for both groups, but still statistically significant. After 12 weeks of therapy, similar results in severity were observed in trial number 2 compared to trial 1. At weeks 4 and 12, both trials showed a statistically significant reduction from baseline in the severity of moderate to severe VMS for Fezolinetant compared to placebo. Again, the graph to the right illustrates the results more clearly. Women averaged a severity score of 2.4, equivalent to a level of moderate to severe symptom severity. At week 4, Fezolinetant cut the severity score from 2.4 to 1.8 or 1.9, compared to 2.4 to 2.1 with placebo. At week 12, Fezolinetant cut the severity score similarly from moderate to severe symptoms to mild to moderate symptoms, compared to placebo. Both graphs above show that the onset of VMS frequency reduction and severity begins after only 1 week of therapy with Fezolinetant. The beneficial effect is observed through 52 weeks. Note the rapid drop in frequency and severity at week 12, when placebo patients were converted to Fezolinetant. Patient counseling. Take 1 tablet daily with or without food at about the same time each day. Do not cut, crush, or chew the tablet. Common adverse reactions are abdominal pain, diarrhea, difficulty sleeping, and back pain. A serious adverse reaction of increased liver blood test values is possible. Blood tests to monitor the liver will need to be taken before starting the drug and at 3, 6, and 9 months of use. Regularly monitor for any signs of liver problems such as nausea, vomiting, yellowing of the eyes or skin, or pain in the right upper stomach. And do not use this drug if concurrently taking medications called CYP1A2 inhibitors. What is the price of Fezolinetant? Astellas has set the price for Fezolinetant at $550 a month, about $6,000 annually. Eventually, this medication will most likely be covered by at least some health insurance plans. However, its ultimate cost, copay, and deductible may remain prohibited for many of its potential users. Astellas does provide a Veozah savings program card where the patient can get their first monthly prescription at no cost. Summary. Fezolinetant or Veozah is an oral, non-hormonal drug used to treat moderate to severe hot flashes due to menopause. Hot flashes or flushes are called vasomotor symptoms or VMS. It's a neurokinin 3 receptor antagonist owning a first-in-class unique mechanism of action. The NK3 receptor plays a role in balancing the brain's body temperature regulation. The dose of the drug is 45 milligrams orally daily. Liver function tests should be closely monitored before the drug is started and for the first 9 months of therapy due to possible transaminase elevations. Fezolinetant is contraindicated in severe renal impairment and end-stage renal disease, in cirrhosis, or in patients taking CYP1A2 inhibitors. In clinical studies, Fezolinetant significantly decreased the frequency and reduced the severity of VMS in patients with mild to moderate hot flashes compared to placebo. At baseline, women averaged about 10 to 12 episodes of hot flashes per day. Fezolinetant cut the number of hot flash episodes down by 50 to 63% by 5 to 7 per day, compared with 33 to 42% with placebo. During the study period, fezolinetant reduced hot flash symptom severity from moderate severe to mild to moderate compared to placebo. The onset of fezolinetant's beneficial effect on VMS started after only 1 week of therapy, and it was observed through at least 52 weeks. The price of fezolinetant is $550 a month, which may make the drug out of reach for most patients. Astellas offers a coupon for a free 1-month supply of the first month's use of the drug. So is fezolinetant worth it? Well, I've given you a lot of information, but everyone needs to come up with their own decision. And while you're here, take a look at some of the other videos on my channel. Thanks for tuning in to watch this installment of the Pharmacy Tutor. I hope you learned something that you could use at school or in practice. If you'd like to continue to see more of these types of tutorials on YouTube, please make sure to click on the subscribe button below to change it from red to gray. Also, if you like this video, I would appreciate it if you can click on the thumbs up icon below to change the color to blue. If you have any comments or questions, please feel free to add them in the comments section below, or share this site with someone else. Stay tuned to the PharmEasy Tutor channel for more lectures in the upcoming weeks. So until next time, remember to take it easy.